You've been provided with the organization's IP risk assessment and plan, and you know they've been struggling with cases of Candida auris among their patients for the past couple of months. Upon reviewing the risk assessment and plan, you observe no mention of this high-risk pathogen. What do? Ask the authors of the document to explain the process for updating and maintaining the risk assessment and plan. Explore the process for feedback and approvals from multidisciplinary partners.
Hi, my name is Cindy, and I'm the infection preventionist from Washington State Department of Health conducting an ICAR in your facility today. Thank you for sharing your infection prevention risk assessment plan. You mentioned that you have been struggling with cases of Candida auris among your patients for the past couple months, but I noticed you didn't mention this in the high-risk pathogen section. Tell me about your process for updating and maintaining your risk assessment. How do you get feedback and approval from your multidisciplinary partners? I would recommend including Candida auris to the plan, and maybe you could consider a process for how to conduct off-cycle updates as risks arise.
Consider recommending the addition and inclusion of C. auris surveillance and mitigation to the plan, as well as establishing a process for off-cycle updates as risks arise.
Watch this video from Fred Hutchinson Cancer Center on isolation precautions.
All right, so lead us into our next conversation on isolation precautions.
Happy. Next slide, please. So studies have shown that some immunocompromised patients have prolonged shedding of viruses as compared to immunocompetent hosts. In practical terms, this suggests that immunocompromised hosts can be infectious for a prolonged period, which results in a need for prolonged isolation. There are several infections listed in the CDC's guidance for isolation that have different recommendations for immunocompromised hosts. However, that guidance is not always well defined and is pretty vague. Statements such as extended duration with no cap on it. So some examples where the CDC has different recommendations include COVID-19, rotavirus, parainfluenza, parvovirus, B19, adenovirus, RSV, and varicella zoster. So it's very important that facilities need to develop policies on when to discontinue precautions for infections that have unclear guidance based on the current literature, your own institutional experiences, and available resources. Sometimes the most challenging part is defining who is immunocompromised, and that may differ depending on what patient population you serve. Another important question to answer is when is it appropriate to use laboratory testing for disease resolution? For example, here at Fred Hutch, for our highly immunocompromised patients, we need to have a negative test to remove precautions for RSV. But things to consider is what testing resources your patients have access to and at what cost. Some of the multiplex testing platforms can be very expensive and not all insurances may cover it. So it may not be practical to test everybody until they're negative, right? So it's very important that you look into all of these things to determine what is best for your facility and the patient population that you serve. Next slide. So another unique challenge to oncology-based IP is isolation in the outpatient setting. So oncology patients often have essential appointments that cannot be postponed due to a patient's infectious status. So I remember like early in the COVID-19 pandemic, there was kind of this feeling when there was this belief of containment that we're just not going to let COVID-19 patients into the clinic, right? That is not practical. Just because our patients have an infection does not mean that they don't need their cancer care. So immunocompromised patients can, again, be infectious for a longer period of time and pose a risk to healthcare workers and other immunocompromised patients in the clinical environments. So we need to create a process to bring in those patients safely and see them in appropriate precautions. Some challenges that we have experienced is developing a chart flagging system and electronic medical record system that's designed for an inpatient setting. Overcoming that barrier can be quite difficult. I'm very grateful that we have Marie, who actually is our EMR subject matter expert in this case.